We think generally of cancer pain as being something that it's not. It's just serving a warning that there's something wrong, but it's not protecting us. It's not doing anything, and so if we get rid of it, it's not going to make the cancer grow faster. Have we considered alternatives? May they be helpful? I'm a huge believer in scheduled Tylenol, and I will not hesitate to use 4 milligrams a day, or at least I use 3 milligrams all the time. Sorry, 3 grams. 3 grams, sorry, a day total. 4 milligrams now, that won't get you very far. Just obviously be very careful that they're not taking from any other source as well. That's the big thing is when they get it from multiple sources. Non-opiates, non-pharmacological strategies, again, a whole other talk. Big believer of cognitive therapy, acupuncture, massage, whatever else, heat. Adjuvants, huge believer for not just neuropathic pain, but really any chronic pain situation. I use a ton of nortriptyline, and a fair bit of, I'll often add on either Lyric or Neurontin to that. You can use Cymbalta if you prefer. It's a whole lot more expensive than nortriptyline. And nortriptyline, I don't even push the dose. I go to 25 milligrams, and I've often had a wonderful effect. Just significant. It just drops the overall pain level down. Slight risk of, as you push the dose, a slight risk of QT prolongation with that and some others. And did they, they say, well, that didn't work. Well, what were they expecting? They take a dose, oh, well, it didn't take away my pain, so it didn't work. Well, that's not how these medicines necessarily work. Some people I have had, they took a dose of nortriptyline and it really made a big difference, but that's not necessarily the norm. It's not going to just take away the pain. It's not an analgesic. And you can use the Controlled Substances Registry. North Carolina has one. You can get online and look at all the prescriptions for opiates this person has had in the last 5 years that have been filled in any North Carolina pharmacy. It can be very useful if you're worried about someone doctor shopping. And I've had that. I've had one person actually going to 11 different pharmacies, something like that, different doctors in 3 different states. But that's not most of these cases. That's rare. That's the drastic exception, as I mentioned before. Most people, they're just going to their one doctor. They just want to find the right one. Okay, which medication do we use? Let's say we are going to use opiates. Well, I recommend sustained release medications. And that was one of the reasons I vehemently dislike the concept of a REMS plan for sustained release opiates. Sustained release opiates are more often associated with a death because they come in a higher dose pill. You can't find 100 milligram pills of just immediate release opiate, but you can find that in sustained release, and then you can crush it and take it. And so, I felt strongly that if you're going to have a REMS plan, which may be worth considering, it needs to be for opiates across the board. And incidentally, Ultram, I have seen 2 people actually go to clinic and go rehab for Ultram abuse. Why Ultram is not scheduled blows my mind. But oxycodone, I don't know. This is purely anecdotal and overall societal issue. But there's a couple reasons I believe oxycodone may be somewhat more euphoria causing than some of the others. So I tend to stay away from oxycodone in patients at risk. I'm not. That's just my personal thinking. It's not dogma. There's some evidence of combining different medications. Using some morphine and some oxycodone and some of this may have additional euphoric effects. Combination drugs, I tend to be very cautious of for a number of reasons, including that if someone is abusing them, they can then kill their liver, which is not going to help them. But they're not outrageous, but they're not going to solve the problem. And I've seen a lot of people think they're safe as long as they're prescribing these. These are the most abused drugs by far in this country, by far. Lortab, number 1, followed by Percocet, followed by the others. So just because you're prescribing these does not mean they're not going to be used. Fentanyl can be useful because it will give a nice steady release. I have had people do stupid stuff like chew them or something, but usually those people, that's pretty extreme, and that's not really a sustainable plan. An interesting option is the concept of buprenorphine, which is they're using that increasingly for, instead of methadone, for maintenance. Instead of methadone maintenance, they're using buprenorphine maintenance. Buprenorphine is used all the time in Europe for pain It is quite effective pain medicine, and it has very little euphoria. In fact, it seems to block euphoria from other sources, so that if someone is on buprenorphine and then they take a bunch of heroin, they're not going to get the euphoria they may get. I think that's, unfortunately, it's either for this reason, for that reason of opiate addiction maintenance, which you need to get some sort of certification, which I hope there are some people in this area who do that, because I think it's huge. Excellent. Good. But I'd encourage everyone to consider doing that. I think it's a great option. In any case, otherwise, for pain, it's only available injectable form here, and that's annoying and may not accomplish the goal of avoiding euphoria. In any case, it has some advantages. I just think that's out there, and you may hear more about it. So, at-risk patient. Now we've got a situation. We have an at-risk patient, and they need an opiate. Okay, it happens. The fact is, everyone gets into hospice. Anyone can get cancer. Anyone can get any number of things. Any number of reasons this person might need an opiate, and it doesn't have to be cancer. I'm not trying to say that. The goal is to choose a regimen that minimizes euphoria. Expectations. People talk a lot about a contract. I think the key is you and the patient understand and explicitly agree on what are the terms here. What is the deal? They are going to be honest with you. They're going to tell you what's being taken. They're going to tell you if for some reason they did go to an ER for a broken leg or something, got something. Otherwise, they're not going to be going to another source. They're not getting other medications. They're not sharing their medications. Now, as far as that, I will put a caveat that I don't believe that we should necessarily say because someone smokes marijuana that necessarily means they should never get opiates. There does not seem to be a significant association there with marijuana increasing risk of abuse from what I've seen, and so I would just not necessarily. I would at least consider that, and maybe they'll be explicit up front if they're explicit up front with you, and then whatever. But that one I wouldn't. But on the other hand, if you're seeing heroin, cocaine, that's a different matter entirely. And just be explicit about what it is up front so everyone knows. You need to be able to call them in at any time to check in your tox screen. If you're going to prescribe it, you need to be able to call in and say, hey, I need you here, whatever, first thing this morning. No early refills, no excuses. Now, if you're evaluating and you need to adjust the medication dose, that's one thing, but I've not had people lose prescription medications as for hypertension. I've not had them get flushed down the toilet. I've not had dogs eat their cholesterol medications. But it somehow happens to opiates for some strange reason. I'm sorry. You make it very, very explicit right up front. Don't spring this on them. They need to know this up front, and they will probably test you on it, some of these people. And then they have to follow the whole plan. They can't just say, well, I'm just going to take the opiate, and then I'm going to go and do my thing. If you think physical therapy is beneficial, they need to do the physical therapy. If they need cognitive therapy, if they need doing whatever else, if they need to be taking the Lyrica, or they need to be doing the whole plan. It's not, because opiates alone, especially for chronic pain, it's not good care. Again, my whole pain talk, I'd be happy to give that for people. That's another, chronic pain in particular, and a lot of the pains need much more than that. And being clear, what is the consequences of violation? Okay, they don't do it. For example, they come in and ask for an early refill. I'm sorry, I'd be happy to give it on this date. And if you have withdrawal side effects, then I recommend you go to the whatever. I don't know. And you can let people know or something. That's going to thrill the ER docs. I don't know, but I don't know. But being in communication with others who would be involved in seeing this patient, so that everyone knows what's going on, is on the same page, is fair. Okay, you're following up. You've got them on. Well, is it working? And don't just say, okay, is it working for you? Yeah, it's working great, doc. Okay. No, well, has it changed what you're able to do? Are you functioning more? Are you able to do things you weren't? And if you can find out what they weren't doing and then they are doing, that's great evidence that it's helpful. You can certainly, it's worthwhile asking about pain level. Like I said, even those people early on, their pain level went to, they told me, and they went to like a 9 or 10 to a 3 or 4. Well, that's helpful. It's not adequate enough. But you'll also find over time, and this has been true, that there are many people that they get titrated way up on high doses of opiates, and at the end, their pain level, they'll swear they absolutely need it. It's made a huge difference in their life. They're doing less than they were before, and their pain level is exactly the same as the ones at the beginning. Well, it's not working for them. It's not, that's an opiate non-responsive pain syndrome. Even though they feel like it's helping, it is not effectively helping their pain. Are they rapidly requiring more and more? Well, that should be concerning to you. Maybe their disease is progressing. Certainly in cancer, we'll see that. And I had one very good informative case. Someone had been, following me for a year. She had been, before I got her, she'd already had like 8 CT scans of her abdomen for this horrible abdominal pain. I put her on, and she was on some, and I got her on a steady release, and she did still go to the ER regularly, for this horrible pain. But she at least was honest with me, and I couldn't find anything, so I kept her on some. CT number 11, they found this tumor, and then they took it out, and the pain went away, or it went away. That really helped me realize I don't know, I can't know for sure, and so that doesn't mean you're stupid, but just keep that in mind. Don't. And I will say also that cancer is often late diagnosed in patients with fibromyalgia or any other chronic pain syndrome because we just dismiss it. If someone has a new pain complaint, it doesn't mean you need to do the full body CT scan, but at least do evaluation, a physical exam, ask them questions, and following up on that, and then if it seems concerning, do appropriate limited studies, focused studies. Okay. Are they following the whole plan? Are they taking all the medications that you asked? Are they really drowsy all the time? And here, sometimes if you can get someone else to tell you, I definitely have had patients say, oh no, I was awake all night, and you asked the nurse and the inpatient, he was sound asleep, we shook him awake once, and he demanded for medication. And he may have felt like that, I don't know, and maybe they're not trying to lie to you, but they may not realize it. But now, urine toxicity, I do want to caution people about. First of all, I'd recommend considering getting one that is aimed at, not at screening for drug abuse, but aimed at looking for whether they're using their medications appropriately. And they're actually test different thresholds and some of the different things. False negatives. I've seen a number of cases where someone clearly was on a stable dose for a long time, and it may have been that the urine was too dilute. It may have been, I don't know why, but and sometimes a lot of these, especially for the semi-synthetics and synthetics, they have a fairly high threshold. So if it just doesn't cross that threshold, it'll be reported as a negative. Well, if you're trying to say, are they on this medication, and you say, oh, well, they must be selling it on the street, I wouldn't jump to that conclusion. I would talk to the lab, see what their threshold is. I would always make sure you know what the specific gravity is to see if it's way too dilute. And think through what if. I had one patient, the most horrible gout I've ever seen, literally pus oozing out of these tophi, and just horrendous. And this public health doc, well, I'm sure it's the drug seeking guy. Well, he was on a low dose, and it was just kind of, Flortab was helping a little bit. I ended up getting him on, I think, MS-Contin, either 30 or 45 BID, twice a day. Pain went down from 9 to a 3. He started doing a whole lot more. He went back to work. Stayed on that for a while. I put him back to the primary physician, who, by their protocol, getting monthly drug screening. Well, for 9 months, everything's great. And then there's one negative. What do I do, doc? Well, has anything changed? No. The patient's doing great. Why did you get it in the first place? Oh, well, and didn't, so well, we'll keep it going, but I need to make sure a year later, the same thing happens. Why, again, don't check it if you're not going to do anything about it, don't go looking for trouble. Because I have no reason to believe it. I'm sure this one guy was not selling on the street. He just may have drunk too much water or who knows what. And again, you can use that registry database if you are concerned that they're shopping around. It will not give you all. It gives you pharmacy prescriptions. When these ER docs give it, it does not necessarily show you that kind of stuff. So it's helpful. It's not complete. You can also use the Western North Carolina data link, which can give you all the ERs and all the things that actually go from the hospitals. I don't know if it has all the ERs, but that can at least give you some useful information. Many of